All right, good morning, everyone. So we're going to get started with our next presentation on HoLEP. Dr. Megan Schaefer is a board-certified urologist, assistant professor, and the Associate Residency Program Director in the Department of Urology at Medical College of Wisconsin in Milwaukee, Wisconsin. Her surgical practice is subspecialized in treatment of benign prostate conditions and stone disease. Her research and academic interests include medical education and the promotion of women in surgery. I have the pleasure of working with Dr. Schaefer in my clinic. She's absolutely wonderful, and her outcomes for her patients are great as well. So please join me in giving a warm welcome to Dr. Megan Schaefer.
Thank you, Andrea. Can you guys hear me okay? I can't actually see anyone right now, so let me know that I'm coming through to you.
You're coming through loud and clear.
Wonderful. Thank you so much. All right, like Andrea said, my name is Megan Schaefer. This morning, I'll be speaking to you about Holmium laser enucleation of the prostate, or HoLEP, a surgical procedure for BPH causing bladder outlet obstruction. I have no financial disclosures. First and foremost, I would like to thank Suna for the opportunity to speak with you all this morning, and specifically Andrea Strong. I can see all that. Let me turn that off. Who, as she noted, is a nurse practitioner with our group in Milwaukee, for inviting me to do so. Like she said, I'm an assistant professor in our department up here, and I also serve as our associate residency program director. My clinical focus, and specifically the majority of my surgical practice, is in patients with BPH. I was born and raised in Eastern PA and then attended medical school at the University of Cincinnati. I came to Milwaukee in 2013 and did my 5-year urology residency at the Medical College of Wisconsin, or MCW as we call it. Upon graduation, I actually took a job with a private practice group down in Chicago, Uro Partners. Some of you probably are familiar with the group. Pretty pervasive down there. And I was there for a year until I was invited to return back to our department as faculty. I really love my job with MCW because it allows me to be subspecialized and also really actively engaged in teaching and mentorship for people in all practices in urology. So our objectives today are obviously to explain the whole procedure in detail for you all, but also to just give some general background and context to the disease state that we are treating with HoLEP. So we'll start with just some definitions to make sure we're all on the same page with jargon, since that can sometimes be confusing and different depending on where you're practicing and what group you're practicing with. So we'll also go through the pathophysiology of BPH. We'll briefly review some medical treatments for BPH and broadly review surgical treatment. We'll discuss the technique for HoLEP in detail and then move on to perioperative care and expectations as they relate to the procedure. Specifically, we'll discuss the expected recovery course and potential complications for the procedure, which may be more clinically relevant for this audience. We'll then conclude with the limitations of the procedure and future directions. So just quickly to make sure we're all on the same page, let's start with some definitions and acronyms. So BPH stands for benign prostatic hyperplasia, which is the histological description for the enlargement of the prostate that we see in men as they age. BPH can cause LUTs, or lower urinary tract symptoms, which are the patient-reported clinical manifestations of this process. We often try to objectify LUTs, which can be quite subjective, using the standardized questionnaire known as the IPSS, or International Prostate Symptom Score. This is often used interchangeably with the AUA symptom score, so that might be a more familiar term. Bladder outlet obstruction can be an objective clinical manifestation of BPH that can be diagnosed by providers. TURP stands for transurethral resection of the prostate, and is the long-held gold standard minimally invasive treatment for BPH in terms of surgery. Bipolar TURP is the most commonly employed TURP modality, although monopolar TURP is still utilized. Photovaporization of the prostate, or PVP, is also commonly called green light TURP and is another form of surgical treatment for BPH. HoLEP, as we've already covered, stands for Holmium laser enucleation of the prostate, in which the Holmium laser is used as the tool to perform an enucleation, or essentially removal of obstructing prostate tissue. So let's briefly review some anatomy here. The prostate gland is a small gland that measures on average about 40 grams in size. So about the size of a walnut is usually what it's compared to. It sits just below the bladder and is essentially kind of continuous with the bladder neck cephalad. The caudal extent of the prostate is the urinary rhabdosphincter. It abuts the rectum posteriorly. And the urethra runs through the center of the prostate, but as I often describe to patients, the prostatic urethra is not really sort of the pipe-like structure that we see in the anterior urethra, but more of a mucosal lining that kind of runs through the prostate. This is of significance later when we kind of go through how TURP is performed. And like I said, often it's really hard for patients to conceptualize how we're going to be cutting the urethra with this procedure. The prostate itself has several different zones. The most clinically significant are the transitional zone where BPH develops, and the peripheral zone, which is where we see most prostate cancers developing. The purpose of the prostate is to produce and excrete different enzymes in semen that support the viability of sperm, specifically in the female genital tract, which is, again, another question that patients always ask when they're seeing you for this kind of thing, and they haven't known for 60 years, but now they want to know if they could do that. Do I still need this? So again, BPH is actually the histological description that has become somewhat interchangeable, though perhaps misleadingly, with the clinical manifestations of obstruction. Again, the transition zone is the zone of interest here. And as men get older, they increase the expression of alpha-1A receptors in the prostatic stroma. These receptors are responsible for smooth muscle contraction. So what we see over time is actually an increase in the tone of the prostate that really contributes to symptoms. These are the receptors that you target with your Flomaxes and medications like that, which we'll cover briefly in a little. And then in addition to increasing in tone with age, the prostate does also enlarge. And this process is mediated by the conversion of testosterone to DHT, which happens through the activity of the 5-alpha reductase enzyme. DHT is a trophic factor for the prostate, and thus targeting 5-alpha reductase with medications like finasteride can slow growth of the prostate and even shrink it to some degree. So again, two major mechanisms at play here: growth of the prostate as well as increased tone of the prostate, which results in restriction of flow. So it's actually the latter mechanism, the increased tone, that is a more significant driver of symptoms for patients, which is why the size of the prostate does not actually correlate with the severity of patients' symptoms, nor actually the degree of obstruction they may be experiencing. And again, I think this is always really important to note, because from a patient perspective, it can be quite a hurdle for them when they've been told by their primary care doctor or marketing or what have you that they have an enlarged prostate and that's their problem. And then they come and see someone like me, who, as part of our surgical assessment and counseling, we often talk very much about prostate size. And if I inform them that their prostate is, a small or average prostate, it really doesn't always connect with them, because they really think it's just the enlargement of the prostate that can cause the problem, but it's definitely not. So I think it's always important just to be really clear on that, because it can be super confusing for patients. So bladder outlet obstruction is the actual clinical manifestation of BPH. And here again, it's important to note that the degree of patient's obstruction not only does not correlate with the size of their gland, but it may also not even correlate with their symptoms. You may have all seen patients who have gone into retention and swear they never even noticed a single thing wrong with their stream. It never slowed down. They were never bothered by any urinary symptoms whatsoever. And they have, 2 liters in their bladder, and completely unbeknownst to them. But bladder outlet obstruction is often a progressive disease state, and the majority of men who do have lower urinary tract symptoms will have worsening of their symptoms over time. Obstruction in men can often lead to storage symptoms too. So those are symptoms like your urgency and your urge incontinence kind of things, in addition to just sort of the classic obstructive symptoms like slow flow and difficulty emptying. What we kind of consider end stage for this disease process is when we get to a point of bladder decompensation. So initially, as the bladder becomes obstructed, the detrusor will compensate by, similar to other muscles, although it's obviously a smooth muscle, kind of bulking itself up or hypertrophying. in an effort to overcome outlet resistance. But over time, the detrusor does decompensate and can even progress to a state of acontractility. And these patients are your patients that you see in, that come in fluid retention. A very classic presentation of this is the patient who gets labs done for some routine reason and is noted to have a significant AKI. They're sent to the ER by their primary care doctor. They get an ultrasound, which shows bilateral hydronephrosis in both kidneys and an overdistended bladder. And then, you put a catheter in them. That's what this picture is showing, obviously a very distended bladder. You put a catheter in them and you get over a liter out. So the risk of progression of this disease there's some correlation here. The risk of progression is associated with larger prostates, as well as patients who have higher PSAs, which can be a correlate for prostate size, as well as older patients. So LUTS, or lower urinary tract symptoms, as you're all probably familiar with, are the symptoms that patients themselves describe as a consequence of their bladder outlet obstruction. They can be multifactorial and highly subjective. So we broadly separate them into kind of two categories: storage symptoms and obstructive symptoms, which I just briefly touched on. Storage, again, referring to a failure of the bladder to tolerate the filling phase. So these are your OAB patients, your urge predominant type symptoms. And obstructive, again, is fairly self-explanatory in terms of the types of symptoms they experience. These include weak stream intermittency, sensation of incomplete emptying, and they can drive frequency as well. So there's always a lot of overlap in these two categories. The IPSS pictured here is the clinical tool that we use to attempt to objectify and then also stratify patients in terms of their LUTs. The first 7 questions of the questionnaire give you a score which determines severity. And then the last question is a qualitative question, which kind of describes the degree of bother. And so I think that's always really important to get for any patient you're assessing for symptoms, and certainly any patient who's had some sort of treatment for their symptoms. A physical exam for bladder outlet obstruction is not as straightforward as it can be for other disease processes. It's not often something you can kind of see from the outside. There may be a role for a digital rectal exam for these types of patients, which can give you some indication of the degree of enlargement of someone's prostate. But as we've mentioned multiple times, that size doesn't always, correlate to their degree of obstruction or the presence of their symptoms. So the DRE is kind of, it's an adjunct. It's good to note, but it's not necessarily going to answer a lot of clinical questions for you. So these are some findings that I would consider sort of objective in terms of an exam on evaluation for these patients. So these include an elevated PVR, which again can also be a nuanced finding, but I would say, a PVR of about 200 should raise a flag in your mind. And then 300 is often used as a cutoff to consider someone in retention, although again, this can be nuanced. Patients can have very different bladder capacities. It's, always important to kind of take into account how much of their bladder they're emptying versus how much they're retaining. And then a low flow on a non-invasive uroflow can certainly be seen in bladder outlet obstruction. We place the most significant on the maximum flow that someone has during that study. So we look at a couple different parameters, their Qmax and their Q average. Qmax is kind of the number that we look at to make sort of distinctions. And 10 cc's per second is pretty generally as accepted as sort of, if you're under that number, you have restricted flow. If you're over that number, your flow is actually pretty normal. And then, if a patient's having a cystoscopy, certainly a visually obstructing prostate, which is what you kind of see in the top left picture here, sort of kissing prostatic lateral lobes, or the presence of bladder stones, and certainly, severe trabeculation in the bladder can all be findings very consistent with bladder outlet obstruction. Urodynamics can offer us a really great functional insight to bladder outlet obstruction. Hallmark findings of bladder outlet obstruction on urodynamics would again be a low Qmax, but specifically a lower Qmax associated with a higher than normal maximal detrusor pressure when voiding. So we use 40 centimeters of water as sort of the typical pressure that most people sort of void at normally. So anything over that, it would be considered sort of a higher pressure. And if you perform urodynamics or read urodynamics, then you've certainly seen those patients come in with pressures of 90 or 100 and flows of 2 cc's per second. That's a pretty sort of classic bladder outlet picture. Compliance is not often going to be impacted in these types of patients. Again, especially if they have a hypotonic or acontractile bladder, their compliance might be great. If you get video urodynamics on patients, you can sometimes see narrowing of the bladder neck and restriction of flow through the prostatic urethra on fluoroscopy when voiding. So those can be some other sort of findings when you're doing urodynamics that you can look for that can kind of tip you off to an obstructive picture. It is worth noting that urodynamics are not indicated for all patients who are being evaluated for bladder outlet obstruction. Instances in which urodynamics may be indicated are if there's a suspicion of a neurogenic bladder. In my practice, if patients sound like they really have storage predominant symptoms, and I really want to prove to both of us that there's an element of obstruction that an outlet procedure would fix, then sometimes I'll get urodynamics for them. Essentially, you don't want to take a patient for surgery unless you really think it's going to help improve their symptoms. And if they're really just leaky and urgent and it all sounds a lot more overactive to me than truly obstructive, then I really want to make sure there is a presence of obstruction to address. But over the last couple of decades, we've seen a lot of changes in the trends for how BPH has been treated, specifically with the introduction of alpha blockers back in the 90s. Utilization of medication has gone way up and surgery has gone down. But as the population continues to age, I think we're going to continue to see an increased utilization of surgical procedures to treat men with BPH, since we know there is a correlation between age and the progression of symptoms. Younger men often want to optimize sexual function, and specifically with BPH, what that means is sort of the preservation of antegrade ejaculation. So they may be a little less likely to pursue a surgical intervention as quickly, although many of the more sort of recent office-based therapies to come on the market, things like UroLift and Resume, are sort of specifically designed and targeted towards men to help preserve ejaculatory function. So those modalities might be a little more appealing to those patients. So here's an AUA guideline. I'm not going to go through the full guideline here, but I think it's always so important to know, what guidelines are out there that can help direct, the diagnosis and treatment for common urologic problems. In 2021, they put out a new guideline for the basic management of LUTS, which includes this really nice flow chart and definitely can help to, guide clinical practice. And everything's obviously very evidence-based. So if you're ever sort of wondering, what do I do next? This is a really, really great reference. So again, just briefly to touch on the medical management of BPH, there are a few common classes of medications that get utilized. Alpha blockers are the most widely utilized and the most effective medication for the relief of LUTS caused by BPH. These can be relatively quick onset and include your tamsulosins, your alfuzacins, etc. These kind of relax the prostate, which is how I sort of explain it to patients, and help open up flow. 5-alpha reductase inhibitors are the secondary sort of most common used medications out there. Those are your finasterides and your dutastarides. The net effect of these medications is to reduce the size of the prostate over time. They can take quite some time to take effect. We typically counsel patients don't expect to see a change until at least 12 weeks of being on these types of medications. And then Cialis is a PDE5 inhibitor, which is a class of medications that's typically used to treat erectile dysfunction that's also approved for the treatment of LUTS caused by BPH in men. So when do we operate on patients for BPH? There are a few what I would consider sort of hard indications to, that exist for when to consider surgical management for BPH. Obviously, one of these is the development of sustained urinary retention requiring the use of catheters. So that doesn't always mean, the first episode of retention. We all have those patients who come in, maybe they had some sort of ortho procedure, they went into post-op retention, they come in for a fill and void. they pass, maybe you start them on an alpha blocker, and they may never have another problem with retention. It can be situational, but certainly if they can't pass their fill and voids, or it's progressive, or it's happening over and over, and they're requiring the use of catheters, that would definitely be, a time when I would say medication alone is probably not going to cut it, and it's time to consider a surgery. Other indications include recurrent urinary tract infections in men. So men obviously are not like women, and that can just be sort of a normal state of affairs. Recurrent urinary tract infections in men, in the absence of sort of other sources like stones and things, can be caused by high pressure voiding. And so relieving patients' outlet obstructions can also definitely improve and or cure their recurrent UTIs. So it's definitely a situation in which to consider it. Certainly if they've formed some bladder stones, again, not only is that pretty pathognomonic for the presence of an outlet obstruction, but they're probably going to require treatment for those stones anyway. So it's very important when you have those patients to also counsel them on the potential for a concurrent outlet procedure to address sort of the root cause of why they're forming stones. Obviously, if they're, on meds and the meds were working, and then over time, they're just not, failure of medication would be an indication for surgery. And then patient preference. I always tell my patients, especially in the absence of any of those other things, recurrent UTIs, retention that's mismanaged, the presence of lower urinary tract symptoms is not a life-threatening issue. It's just a quality of life issue. And so how we decide to treat it is very much based on patients' values and patients' preferences, right? So some people would rather just stay on a medication for life and say, I would never want surgery unless I needed it to save my life. And that's just one set of values, and that's totally appropriate. And other people would say, hey, if you can get me off this med and that can fix the problem once and for all, let's go ahead with surgery. So patient preference is absolutely an indication. So again, when it comes to consideration of surgery for patients with BPH, the AUA has a really nice flowchart as a part of their guideline. They put this out in 2018 and then revised it in 2019. I don't know if you guys can see this little window, if that's in the way for you. And it sort of helps direct what may be sort of the best, or at least the most appropriate modality for patients based on obviously a very deep review of the literature and what's out there. And you can kind of see here, the crux of this algorithm is really the size of the patient's prostate. That's really what kind of sets you from one, set of options to another. So when I'm evaluating a patient for BPH surgery, there are a few key pieces of information that I want to know about them. So in addition to what their symptoms are like, what their flow is like, all the things we kind of talked about to this point, I think a very critical piece of information is going to be the size of their prostates. The size of a patient's prostate can be obtained a couple of different ways. If they have cross-sectional imaging in their chart from something else, they were in the ER and they got scanned, and you have a CT of their abdomen and pelvis, you can calculate their prostate size from that. If they've been evaluated for elevated PSA and they have an MRI, obviously that'll give you a volume. If they don't have any of these items in their chart, then I will often get a transrectal ultrasound of patients just in a clinic setting to know exactly how big their prostate is. It's also important to know the status of their detrusor, whether it's still functioning, whether it's completely acontractile, or even just a little hypocontractile. Because again, this is going to direct surgical therapy, and we're going to talk about that a little bit, obviously, in the context of HoLEP in just a minute here. And then it is important to know some of, patients' medical comorbidities. Do they also have stones that need to be treated? Are they on blood thinners? And if so, can they come off of those blood thinners, or do they need to stay on uninterrupted therapy? So this kind of brings us obviously to the point of this lecture, which is to describe to you what HoLEP is, how it's performed, and who may be appropriate for this procedure, and then what people caring for urologic patients undergoing HoLEP may need to know. So what makes HoLEP unique And in my opinion, and in the opinion of a lot of BPH people out there, kind of the sort of new platinum standard for surgery is that it's an appropriate surgery for patients regardless of their gland size. So whether they have a tiny gland or a massive gland, HoLEP's been shown to be effective and certainly superior at removing more tissue for those patients with larger glands. There are several trials out there that have directly compared HoLEP and TURP, as well as green light PVP or green light TURP, and demonstrated a sustained superiority of HoLEP over time versus those other modalities. So what HoLEP has done is essentially replace the simple prostatectomy, which is what, especially pre-robot era, what we used to do for patients who had really, really large glands. Now with the use of the robot, people can also do a robotic simple prostatectomy, and that's obviously less invasive than having an open surgery. There's not a lot of really great direct head-to-head comparisons between HoLEP and robotic simple prostatectomy, but they're very similar in terms of improvement in flow afterwards, improvement in symptoms, sustained results over time. The big difference is that even with the robotic procedure, you're still going through someone's abdominal cavity. So the potential risk for serious complication is going to be higher in a robotic simple prostatectomy, even if the overall incidence of those complications is relatively low. People are really, we know that HoLEP has great results for 7 to 10 years. There's a lot of really good published data out there on that. And now people are starting to release their 20-year data, which again shows that reoperation rates for HoLEP are less than 10%. So really good sustained durable results for this procedure, especially compared to kind of the classic TURP. Because these patients are only requiring one procedure over their lifetime, there's also a cost benefit both to the patient and the system. So HoLEP was brought to the States in the early 2000s. I believe it was originally developed in Europe. Basically what it is, again, it's an enucleation procedure. So we're removing obstructing tissue, but instead of sort of piecemeal kind of scraping it out, like you can kind of see in the bottom left picture of the orange there, that's sort of a traditional TURP model. What we're doing, and we often do describe the prostate as like an orange in this situation, is we're essentially cutting through the segments of the orange until we get down to this rind of the prostate or of the orange. And then, we're really working in kind of a 360 fashion to kind of scoop out all of this tissue. And so if you look at the sort of top part of that graphic, it's kind of showing you basically what tissue is being removed. And then you can kind of have a sense for how open that fossa is afterwards. HoLEP can be broken down into steps. So we start the procedure by sounding the patient's urethra and inserting a scope. We then insert the laser fiber, which it just gets really hot at the tip, and it kind of cuts through the prostate and mucosal tissue, very similar to how a scalpel would. So it's very precise, but because you're using heat, it also provides a coagulative effect at the same time, which can be really good for bleeding. So we start basically at the bladder neck, usually in a sulcus. So if a patient has a big median lobe, you kind of start on one side or the other, and you kind of cut down, you make your cut from the bladder neck sort of distally towards your verumontanum, and that's sort of your distal boundary of where you're working, because beyond that we have the rhabdosphincter, and obviously we don't want to get into that at all. And then we take that cut and we deepen it basically down to this capsular level. And that's, depending on the prostate size, that can be a really deep cut, or the floor can kind of be right there. From there, we kind of come all the way back to where that viru is, and we make a little apical incision in the mucosa. And again, we are working mostly, now that we've established that deep capsular layer, we're working mostly in that capsular layer, and we're kind of coming around the prostate up into the anterior space of the prostate. And so it's actually in this anterior space. So again, if the patient's laying down, you have your scope through the lumen. We're now working above the prostate from where we entered things. And we're going to work in that anterior space again to get back into our bladder. So we kind of work cephalad. And in this space, you can really see the fibers of the bladder neck really well. It's always a really good anatomy lesson, especially for residents. You can see circular fibers, and you'll hit the vertical fibers of the bladder neck. And that's when you know you're basically at bladder again, and you kind of cut through those and you enter into bladder. And then we perform what's called the enucleation, which is basically just freeing up all that tissue in that 360-degree fashion so that it can kind of get pushed up into the bladder. A lot of the times we'll split that in half, split it into 2 lobes, especially if it's a really large prostate, just so we can actually get it into the bladder. And then we use something called a morcellator, which is what the picture on the bottom is showing with that sort of metal rod in the center of the photo. So a morcellator is just, it's a little bit smaller than a pen. It's hooked up to some suction, and it has a little oscillating blade on the tip of it. And so what it basically does is it just chews up this enucleated tissue and removes it. It sucks it out. There's never really a delicate way to describe that, especially for patients. And so once all the adenoma is removed and you have good hemostasis, which you can put the laser back in to obtain hemostasis. I usually kind of do a round of sort of spot coagulating any bleeding vessels before we morcellate. So when we're done morcellating, we're kind of just done. We'll put in a 3-way catheter and place the patient on continuous bladder irrigation. It is worth noting, put 60 cc's in the bladder in the balloon of the catheter in the operating room. And that's to prevent it from falling backwards into that wide open prostatic fossa that we've just created. And I think this is something super important to keep in mind for HoLEP patients is how their anatomy, again, we're removing so much tissue. We are altering their anatomy in that way, and it can create some problems with catheters in the future. In our practice, we keep patients overnight for observation and have them do a fill and void in the morning with our nursing staff on the floor. The majority of them will just go home without a catheter, which for your chronically cathed patients, this is just a miraculous moment for them, and they're always so happy and so grateful. Depending on how your practice is set up, so some urologists will actually just send patients home the same day with the catheter in place and have them come back to their clinic for fill and voids, a day or a few days later. We've toyed with the idea of doing that in our practice. Oh, there's my cat. I hope you didn't see that. The workflow doesn't work for us, and we are really high volume. So I think it would generate a lot of after hours calls to our nursing triage and also our residents on call to be sending a lot of patients home with catheters who aren't maybe used to managing catheters. And there are some centers, Northwestern down in Chicago with Dr. Krambeck being one of them, that will perform a fill and void in the recovery room and attempt to send patients home the same day without a catheter. We're kind of redoing our procedure space up at MCW, and that's sort of my goal. Once we're kind of right now our patients go to recovery really far away from us, and it's really hard to kind of keep close tabs on them. But once everything's a little more centralized, I think that'll start to be some of our objective, is to at least start to get some of the patients from the beginning of the day home same day without the catheter. So again, sorry, my cat has just jumped on this table and really threw me off. So what's made HoLEP what people would kind of refer to as the platinum standard for BPH therapy is because it can really be a one-size-fits-all procedure in the sense that your gland doesn't have to make a certain size cutoff. You can see here, any patient of any size prostate is eligible for a HoLEP. The other important thing is, again, so historically when patients would come in with these end-stage bladders, we would tell them, well, TURP is not an option for you, because we knew from experience that you could TURP those patients and they still wouldn't be able to void volitionally after their TURP. HoLEP has changed that game. There's a lot of really great published series out there on patients who have hypocontractile and acontractile bladders getting catheter free after HoLEP. The sort of highest end quote of catheter free rate after HoLEP in those patients is about 75%. We've actually looked at some of our patients in our own practice who have smaller glands, so you're less than 40 gram glands, and acontractility or hypocontractility. And we have noticed that the catheter-free rates for those types of patients is going to be a little smaller. And it just makes sense. If you're able to remove more tissue, you're giving patients a wider outlet to get urine through. And a lot of these hypo or acontractile patients are going to be voiding not because of their detrusor. You're obviously not fixing that, but they'll be able to utilize a Valsalva maneuver and then actually push their urine out. So the more tissue you have to remove, the wider open they're going to be able, the channel they're going to have to push their urine out. So there is definitely some size correlation with effectiveness, but either way, 55% is better than anything else out there for those patients. So I always tell them it's definitely worth a shot. And then there's a lot of data or a lot of published series out there of patients staying on their anticoagulation for HoLEP. I don't have a ton. I feel lucky so far in that the majority of my patients are able to come off of anticoagulation when they have HoLEP. And so I think myself and really any surgeon, that would be the preference, is to have your patient off their blood thinners for surgery. But if for some reason they really can't come off, maybe they have a mechanical valve, or, they recently had some sort of vascular incident, but you still want to do their outlet procedure and they need to stay on some of their anticoagulation agents, you can perform HoLEP while patients are anticoagulated. So it can be safely done for that, although from a sphincter tone standpoint, I try not to do that. So I just wanted to briefly mention HoLEP versus ThulEP, which is something you might have heard about. I know when I was down in Chicago, there was someone at UIC doing ThulEPs. They're conceptually the same procedure, but you're using a different type of laser energy. So Holmium versus thulium. They generate their energy differently. And so the way that they interact with tissue can be very different. So most surgeons will either perform one or the other. I haven't done a ThulEP, but from the videos I've seen and from people I talk to who have kind of had experience with both, there's a lot more tissue interaction with ThulEP, which is great from a hemostasis standpoint, but can cause a lot of charring and distortion of the tissue planes. So for me, I'm really reliant on the recognition of those tissue planes to tell me that I'm at the appropriate depth and in the appropriate sort of layer all the way around the prostate. So I'll probably just always do Holmium because that's sort of the look of things that I'm used to doing. But they're pretty similar procedures. So how do we prepare patients for surgeries? What should they expect and be counseled on? In terms of complications, bleeding is the most common immediate postoperative complications. Significant bleeding requiring transfusion or repeat procedure is exceptionally rare, happening in less than 1% of patients. But this is why most patients are going to be on CBI postoperatively, or at least left with the catheter. As with anything, there's a risk of an infection at the time of the procedure. We always check a pre-op culture and put patients on prophylactic antibiotics if their culture is positive, and certainly give them intra-op antibiotics regardless of their culture status. In theory, there's always a risk of injury to the bladder during the procedure, specifically with the morcellation step. Knock on wood, this is extraordinarily rare. I have not had this, but it's been described. Anytime we do any transurethral procedure, there's a risk of developing a stricture or bladder neck contracture for patients as they recover. The rates of stricture or bladder neck contracture are about 2 to 3% for HoLEP and for the majority of your transurethral procedures. So it's not significantly different from any other type of transurethral procedure that you're doing where you're removing prostate tissue. And those strictures and bladder neck contractures typically develop within the first 12 weeks. So we keep an eye on that. I'd say the biggest thing that I talk about with people in regards to HoLEP is the risk of incontinence. So it's really well known and well described that about a third of patients will have some what we call transient urinary incontinence following the procedure. Some of that can be stress from pressure on the sphincter during surgery, as well as, an overall rapid decrease in outlet resistance with the adenoma being removed. And some of that can be urge. So it can be a very mixed picture. Again, for the majority of patients, this is temporary, and I counsel them that, of the third that may experience some incontinence, In my patients, 70% of them are going to be dry within the first month, 97% are going to be dry within the first 3 months, and 99% are going to be dry at a year. So your long-term risk of incontinence, and that's typically a stress incontinence, is about 1%. Patients obviously ask about sexual side effects of this procedure. Because we're working within the prostatic capsule, we shouldn't be near the nerves that control erection, so we don't see a significant decrease in erectile function following the procedure. But again, because the bladder neck is wide open following this surgery, it's really common to see retrograde ejaculation. And so I just counsel patients to expect it. In the recovery period, we advise that patients keep their activity light for the first 3 weeks or so following surgery. Essentially, while they're still just seeing blood in their urine, they're not going to cause any harm to anything. We just don't want them to cause a bleed. Patients can describe like a terminal dysuria. That's the sort of extent of pain they have after this type of procedure. It's really common in the short term. It can last up to 12 weeks, but they'll kind of describe a pinching or burning or stinging with urination towards the end of their stream. And we think, that capsule's really distended when their bladders are full. And then as they empty and everything kind of collapses, you kind of have this raw surface that rubs up against itself. And then we already kind of covered the incontinence. So things to kind of consider if you're taking care of a patient who's had a HoLEP. Obviously, catheter placement can be a little more challenging because they do have this really large open fossa. Consider using a coude tip catheter to kind of overcome that sort of up and in that you have to navigate. And then consider inflating the balloon with over 10 cc's to prevent it falling back into the fossa, especially in that immediate postoperative period where things are really wide open. If they're a little further out, things may have contracted down just a little bit, and then you might be able to get by with a 10 cc balloon, but it's never going to hurt to put like 20 or 30 cc's in the balloon just to make sure it really stays in the bladder and doesn't retract into that fossa, because obviously it won't drain there. If patients are having a significant leakage, some incontinence tools are obviously Kegel exercises in the immediate postoperative period. If my patients are having a hard time performing that on their own, or they're really having a good degree of leakage, I'll send them to pelvic floor physical therapy pretty quickly postoperatively just to help with that progress. And then we can give patients duloxetine, which is an antidepressant that has been shown to increase urinary sphincter tone. That can be helpful for these patients. Honestly, a ton of them, they really don't require that. So I don't give that to a lot of patients, but people certainly do. So typical follow-up, I'll see them for a first post-op visit at about 3 weeks. We'll get a uroflow and PVR just to make sure things are open and that they're emptying. We'll review their pathology at that visit. We see incidental prostate cancer in about 8 to 10% of patients, and that's pretty standard. The next visit is going to be at 3 months following that 3-week visit. At that time, we're sort of looking for the development of a bladder neck contracture or stricture in that period of time. So again, uroflow and PVR is going to be really important. At that point, you can get a symptom score on them. In those first couple of weeks after surgery, again, if they're having incontinence or they're having, if their bladder's a little irritated and healing, their symptom score isn't going to be a reliable thing. So I never check that until they're kind of well out from surgery. And then you'll get a PSA if indicated if they're still in that screening age group. And then I will typically follow them up at a year post-op, again, just to sort of make sure their results from surgery are sustained. We'll get a uroflow, PVR, a symptom score. And then after that, I have them return. Well, I'm a softie, so I always say you can come back and see me yearly if you really want to. Otherwise, you can just come back and see me as needed. And again, sort of discharging them to their PCP for PSA screening and things like that is very appropriate. So I would say, in thinking about the limitations of HoLEP, the biggest one is just the availability. So it's still performed. I think the most recent data is out of all BPH procedures, it's performed 8% of the time. So it's still a pretty low utilization of the procedure, even though it's such a great procedure. The reason for that is because it's a pretty technically challenging surgery to learn. So if you were sort of an established practicing urologist, it's probably not going to be something you're going to pick up when you've been used to doing TURPs for a long, long time. As it's becoming more and more popular, and certainly as the data looks so good for it, people are definitely trying to learn it in residencies. We have several of our trainees who have gone out into practice right from residency and are able to perform HoLEP, or a lot of people will seek out a fellowship to learn how to do the procedure. So in conclusion, HoLEP is an extremely effective form of surgical therapy for patients with bladder outlet obstruction for BPH. It has demonstrated superiority over other modalities out there, specifically in terms of durability or not needing a repeat procedure in the future. Patients who undergo HoLEP have the lowest retreatment rates. It's effective for large glands, small glands, functioning or non-functioning detrusors, which is why many would consider it sort of the best option available. It can be safely performed on anticoagulated patients. And then from the patient perspective, the recovery course is very similar to like a TURP or some of the classic procedures that are out there. The biggest issue with HoLEP is the access to the procedure itself. I think that obviously as more surgeons learn how to do it, we're going to be seeing a lot more patients having it done. And I know we have a big referral for a big referral line for this, so we do a ton of them. I know it's similar for centers down in Chicago who are now doing them too. So here are some references. And then I'm happy to answer any questions. And that's one of my patients, really happy after his procedure on the dock there.
Well, that was really great. For those of you in the audience that have a question, we do need to bring a mic to you because this is the only way that Megan will be able to hear us. For those of you that are watching this live and have a question, go ahead and put something in the comment zone. We'll be glad to answer those. I have a quick question. So how long after the procedure do you have to wear the catheter?
So again, for our patients, we just keep them overnight with the catheter and they'll have it removed the next day and go home without it typically. If they're having some trouble emptying, we'll actually preferentially teach them CIC because you'll see as their bladder gets used to cycling again over the next couple of days, they'll really require catheterization less and less. So our preference is if you can't void the next morning, you learn CIC and you just kind of keep track of how you're doing. Again, it depends on how your practice is set up. But I do think in that way, it's definitely superior to like a simple prostatectomy where you're making a cystotomy. So those patients always have a catheter for about 7 days after surgery, just while their bladder is healing. But for this, most people will go home the next day, no catheter.
Oh, that's encouraging. Questions in the audience? Don't be shy. Nobody wants to talk on a microphone, I think.
My question is, if a patient would need an indwelling afterwards, after it was taken out and then they went home and couldn't void, how long would they have to have that 60 cc's back into the balloon for the indwelling catheter?
It's a good question. So we put 60 cc's in the operating room. When our patients go home, like if they are refusing to do CIC or they try and they can't do it and we replace an indwelling, we'll only put 30 cc's in for them to go home with, just because that is a lot of volume in the balloon itself. And then like if they're going to go home with an indwelling, I usually try to have them come back within that first week for a fill and void. Because again, if they're not going to void immediately after surgery, the most common reason is just because of overdistension, during the procedure with the combination of the general anesthetic that can cause retention for any of these types of procedures for any patient. And so that's going to be a pretty limited situation. So you do want to give their bladders a shot. You want to give them a chance to cycle. So we don't want that catheter staying in too long because we want to see how their bladder is going to do.
Great. We do have a question that came in from our UroNurse viewers. How long is the procedure? How long does it take?
That's a really good question. So this is definitely something that gets to the learning curve. So if you have an experienced person, so at our center, if you have like an 80 gram or less gland, we can do that in about an hour and a half. The larger the gland, the longer it takes. So once you start, we've done, and I think my largest like volume enucleated was like 296 grams. So that person had an over 300 gram prostate, and that probably was a 3.5 hour procedure. So it can be really long if they have larger glands, but also depending on how frequently the surgeon does the procedure, it can take longer for someone who's doing less of them. But I tell patients on average, it's about a 2-hour procedure.
Do have another a question coming in. Post-op monitoring. Do you have many patients who have TUR syndrome post this procedure? What to watch for in these quick interventions post-op?
Sorry, thanks. I actually can see sorry, my
You
brain's
can read
going
it.
ahead. I can actually see the questions, but I appreciate that. So TUR syndrome is something you're going to see when you're using a hypotonic solution while you're doing your procedure. There's not really, that's the beauty of like what bipolar TURP brought to the table, is that patients didn't need to use like water or glycine or anything anymore, which is really what's responsible for TUR syndrome, is that they absorb this hypotonic solution. Same with HoLEP, you can just use normal saline. So we don't see a ton of TUR syndrome. I would say actually what happens more if it's going to be a really long procedure, and we've talked about the benefits of warming the solution. I had one patient where it was just a really big gland and it was taking a really long time, and he just got really cold from the irrigation itself. But not often that we see like a true TUR syndrome anymore, because we're just using normal saline as our irrigant. Now, that being said, they still can have some degree of absorption that can just cause an overall volume expansion for them without some of the sort of sodium and other electrolyte changes you see with TUR syndrome. So I give every patient 20 milligrams of Lasix once we start the morcellation step. That's just going to help them mobilize any fluid that they have absorbed during the procedure. It's also going to help with their urine output in the post-operative setting, which is obviously going to keep our CBI clear. So, and that's a pretty standard protocol where patients will get about 20 milligrams of Lasix as you're kind of finishing things up.
All right. Any questions in the audience? Feel like Phil Donahue. I'll run right to you with I think we're good. I had one question. Are you familiar with the procedure where they use the water jet to carve out a prostate?
Yep, aquablation.
Yeah. How do you compare with the two?
So I've never done an aquablation, and obviously I'm a HoLEP surgeon, so I'm going to be biased a little bit. Currently, aquablation isn't recommended for patients who have over 80-gram glands per the AUA's surgical algorithm. That being said, people are definitely doing them on larger glands and reporting their data on that. I think my issue with the aquablation is that, you know, it's supposed to be sort of ease of procedure. You basically map out a prostate and hit go, and a robot sort of follows the mapped course and blasts this really high powered jet at the prostate tissue to ablate it. But then afterwards, most people will go back in with like a TUR set where you've got this loop on your scope that is hooked up to cautery and actually cauterize the beds, because otherwise I think there can be a lot of bleeding issues following aquablation. So for me, I don't totally know what the benefits are. Again, I'm so biased and we have such a large referral base. I've seen some patients who have failed aquablation. I think it's one of those things where if you're not in a place where someone is a skilled like HoLEP surgeon or unable to do like a robotic simple prostatectomy, it's probably a good tool.
Okay, thank you. If there's no other questions, we appreciate your joining us today for the show. We're really glad to have you. It was a great presentation.
Thank you guys. Have a good weekend.